respiration. Put it this way, if they're not done, that's what I will be working on Friday. I'm going to be the tutor anyway on Friday morning until 1 because Jackie got accepted in nursing and there's some kind of meeting. So I'll be in the lab or whatever, so. Yeah, it's one of those things that you wear it and it's on the little case. Yeah. It sticks on a shirt like that. Yeah. All right.
Hello, sir. We'll do better before we take the lunch. Be prepared.
She'll probably still be wearing that when they graduate from college.
I'm like, it's my baby.
That's sweet.
And if you have too many kids, that'll be the last picture you took.
Not too many. No too many no more. I did. Thank you.
Get out your respiration notes. Oh, wait a minute till everybody gets here. This is your study guide for Lab Exam 3.
I said, tell somebody's got them too. How are you?
Man, that was tough.
It was.
Terrible.
I went in feeling really pumped. I came out beat down.
I told you, everybody thinks these first two are the two bad lab exams. It gets better from here, according to the students.
You beat me down today. It was hard.
Yeah, I'm exhausted.
You can't fake it, you
haven't
either
slept in
know.
like 2
Y'all need to
days.
be quiet, there's other people in here.
What's the word? What'd you say?
So, no one put a note under my door saying they did not wish to have the respiration test by itself, so the respiration test will be a 50-point test, and then when we get to digestion, it'll be a 50-point test, so it will go in as your third test. So a week from this Monday will be respiration test, a week from this Monday.
So that will be a Monday. So not Monday, but next Monday.
Unless that's you. Are you sitting right in the second chair? Then I left you one. Okay, you should have out your respiration packet. What is this called? Ventilation. And if you're doing that in a sedentary state like we are right now, what's it called? Costal breathing. Not what is the quantity you're inhaling and exhaling. That quantity is tidal volume. But when you're doing restful breathing, that's called costal breathing. What's it called when you're using serratus anterior, trapezius, rhomboids, levator scapula to help you? Diaphragmatic breathing. That's what you call labored breathing. Okay? So if you'll find those pages that we were on, So if you're talking about inspiration, inhaling, yes, we know the major force that drives movement of air in the respiratory system is what? Air pressure, yes. And it follows a gradient, so it goes from higher air pressures to lower air pressures. So we went through all this diagram. If your standard atmospheric air pressure is 760, and when you inhale and enlarge the size of your thoracic cavity wall, then this pressure of the entrapped air gets less. So let's say it's 756, then that's why the air rushed in and inflated the lungs. So we've been over that once in lab and once in lecture. So we know it's obeying a pressure gradient. But in addition to that, other things that help inspiration occur is cohesion. Cohesion is when like things stick together. Well, lining the inside of your thoracic cavity wall is what membrane? Right here. Not visceral. Parietal pleura. This is parietal pleura right here. But stuck on the outside of your lungs right here is, yeah, that's visceral pleura. Well, both pleural membranes secrete serum. Serum is like a watery lubricant that keeps the membranes lubricated. But when before you did inspiration, this parietal pleura was resting against this visceral pleura. So as you start the inspiration effort and you're moving that rib cage up and out, as it goes out, this tends to adhere to that. It is cohesive, like bonds to like. And so it helps to drag your lungs open because of these membranes having a cohesive property. The other thing is on the inside of the lung, there is a lubricant, a lipoprotein lubricant that you're supposed to have secreted, and that makes the insides of the lungs not tacky, not sticky, so that when you're trying to pull the lungs open, they're not stuck together like two pieces of saran wrap. So surfactant in here, and then the binding together of the parietal and the visceral pleura on the outside are other things that help you. Now we exhale. This is just a study about the last. When you exhale, your your thoracic cavity wall went down and in, so it crowded the entrapped air, so it drove that pressure up. Now it's over 760, let's say 762, and if out here in the air it's still 760, then that's why, according to the pressure gradient, it moves from higher pressure in here to lower pressure out there, and the lungs deflate. In addition to the pressure gradient, what are other things that tend to help you exhale? Well, gravity, because gravity is going to tend to want to collapse those lungs back down. So that's going to help you. And if you have healthy lung tissue, in other words, you're not suffering from emphysema or something like that that made you lay in collagen so you can't collapse your alveolar air sacs, then the natural elastic recoil of the alveolar sac wall will help you. This is one of the walls of an artery, and the alveoli are some of the most abundant elastic connective tissue in the body, because those are things that have to be able to stretch and then recoil back to their original shape. Are you okay on those comments? Okay. Where we're going next then is to talk about general behavior of gases, because that's going to have to do with which way gases move in the human body. So you will have some of these laws on your test, but you've got to really know them, because if it's a matching, and it is, sometimes it's multiple choice, but there is a part on your test that will be matching. If I've got the word Boyle's law, Charles's law, Henry's law, Dalton's law, it's not going to make it easy for you to know who to pair it with unless you really know what happened under that particular law. So you will see this again. Before we get started, just some general rules we know about the way that gases behave. So that's not bases, that's gases. So fix that. Physical laws of gases. When you were studying this periodic chart in Anatomy 1, you said the way that things are found more common in nature is as a solid, a liquid, or a gas. If you're a solid, you have Brownian motion, but it's real slow, very little Brownian motion. If you're a liquid, the atoms are colliding a little bit more quickly. But if you're a gas, that's the state of matter where the atoms are in highest rate of Brownian motion. So that's what made you a gas. And so because the Brownian motion, random vibrations are occurring, then the gas particles will collide, and anything that collides tends to scatter, and therefore it's dispersing, and it's putting pressure on the walls of whatever it's contained in and trying to escape if there is a pore or a passageway that it can get through. So collisions, dispersal, and then exiting wherever you are if there's a way out. Higher temperature. Temperature is a form of energy. So the higher the temperature, you're adding more energy into the situation. That will just make the Brownian motion and the collision rate increase, and therefore distribution of gases will even be faster. So that's just one more thing that can accelerate that. So we know that that's how gases behave in general. So let's get on with these 4 basic gas laws. The first one is called Boyle's Law, and my example for Boyle's Law is a balloon story. In learning these gas laws, it's kind of artificial because you have to pretend like you're going to keep one thing constant and it's never going to shift at all, and that's not really how it is out there in the environment. But we're going to pretend that temperature is not changing. Whatever it is, the temperature is static, which means that's not going to affect anything one way or the other. Let's say you finally got through to a nice holiday weekend and you decided to take your little child or some little kid you love to Disney World. And so there you are walking along, and they want that little Mylar Mickey Mouse balloon. That's a study guide for Lab Test 3. And so it's tied with a little ribbon on the little girl's wrist all day long, and y'all have had such a nice day in the park, and then you're on the way back out to get on the tram to come home, and the ribbon lets go, and there goes Mickey. My Mickey, my Mickey. What's going to happen to my Mickey balloon? What is going to happen to the Mickey balloon as it goes up, up, up? Roswell weather balloon. It's going to expand and burst. Why did it expand? Because the higher you go in the atmosphere, the gases are thinner. The air is thinner. Therefore, it's not pushing on the wall of the Mylar balloon. So the gases in the balloon are under less pressure. They can expand and expand, and they can push outward on the walls of the balloon. So the entrapped air expands, and eventually the balloon bursts. So what we're saying then, to put this into perspective, as pressure goes down, what happens to the volume of the balloon? It goes up. So they're oppositely related. That's known as something that is inversely proportional. So that's Boyle's Law. Boyle starts with a B, balloon starts with a B. Hopefully you can remember how that works. Okay, Charles's Law. I want you to think of your car, a car tire. There's a car tire in the heat of summer, and there's a car tire in February for our 2 days of winter. You had your 1 day of fall last Sunday. Now we're back to muggy again. But anyway, This time, pretend pressure is constant and that that's not going to change. And again, that's a very artificial scenario right there. So we want to look at the effect of temperature and volume. So we're looking at hot roads on your tire and a cool road on your tire. And you got to go from here to Bartow, and you've got a bubble on your tire. Your tire's old, it has a weak spot, it's got a bubble. Are you more likely to make it to Bartow in the summer on a hot road or in the winter on a cool road?
Winter.
In the winter, because temperature, the higher the temperature, it's going to make the gases in the tire occupy a bigger volume. So it's going to push on that weak spot, and it's going to blow that tire more likely when it's hot. Okay? So in this case, as temperature got higher, the volume of the gas got higher. So we call two things that go up together directly proportional. So those are directly, they're not opposites. And so these are rules that gases would behave in a similar way in your body. Henry's law. You may be familiar with Henry's law since you are in the state of Florida. If you do scuba diving, you have to be familiar with Henry's law. If you go scuba diving, you get compressed air in an air tank to breathe. That's just normal air like in this room. They don't do anything special to it. They don't change it in any way. It's just air like you're breathing right now. When you start diving down and you're breathing the compressed air, the deeper you go, the weight of the water puts pressure on your body. The higher the pressure, the easier gases dissolve in solution. So going down is not a problem. You're breathing the air, the little bubbles are dissolving nicely in your body fluids, going out there to your tissues, and everything's cool. But when you come back up, they read you the Riot Act. When you ascend, they say, look at, as you're exhaling, bubbles are coming out of everybody's, what do you call it? Snorkel. But anyway, they say, look at the bubbles that are going towards the surface. Pick out a bubble that's the size of a little green pea, an English pea like you would eat. And don't come up any faster than that pea-sized bubble is ascending. That way you're not coming up too fast. However, if you watch that little green pea-sized bubble, as it comes out from under the weight of the water, out from under the pressure, it gets to expand. So as it reaches the surface, it's expanding more and more. So you have to keep picking another small English pea-sized bubble and only go up as fast as that size when it's small, because it'll start rocketing to the top as it expands. If you don't, just what you're seeing happen to that English pea-sized bubble is going to happen in your body. Little gas bubbles are going to expand in your body if you come up too quickly, and they're going to rip apart your delicate alveolar air sacs in your lung, or nerve tissue in your brain, or blow your eardrum out and rupture it. It's luck of the draw where a bubble is in your body when it decides to expand. You can't control it. And is that going to hurt? Yeah, like hell. That's why it's nicknamed the bends, because it hurts really bad if you don't take the time to decompress properly. So it's called decompression illness, or it's called Caisson's disease. What's a caisson? This is where they first found out that pressure and gas solubility was a problem. When they were building bridges over rivers, some rivers are very, very deep. So they'd have to get the piling for the bridge to stand on down to the bedrock, or it would just keep sinking in the ooze at the bottom of the river. And so they would go down there and they would build caissons, which are cinder block bunkers. And so they'd go down there and lay the block, and then once they got it built, they'd pump the water out of it, and then the workers would be down in this caisson sealed up where they could start building the big pilings that the bridge was going to be standing on. Well, that whole caisson bunker was surrounded by river water or ocean water. So whatever the pressure was is what the pressure was inside that caisson. And as long as, and they might be down there for hours and hours working. But when they came out, they didn't realize it. And then they got the bends because they didn't decompress. Even when you're scuba diving, you're not always allowed to just come up at the rate of that little English pea-sized bubble and keep coming all the way to the surface. Sometimes you come up and they say, I've made a knot on the anchor rope. You people stop at the knot on your anchor rope, hang on and breathe there for 10 minutes. What that does is let everything that's trying to bubble out a solution bubble out and let you exhale it the proper way. Don't keep coming up or it'll keep expanding. So you got to stop a minute and blow off some of the bubbles that you've accumulated that have come out of solution on the way up. Then if you were really diving deep, you might have to stop at another knot on an anchor rope. So they have ways of getting you to stop at the right point. That's why you really shouldn't go scuba diving if you don't really do it all the time and have the rules clearly memorized yourself. You should go and get a, what's the name? Anyway, an instructor. I can't think of what you call him. But to always be there, dive master, so that he can remind you. Now we're going to come up, but we're going to stop here for 10 minutes so that you can't make any foolish mistakes. Let's say you goofed up anyway and you got decompression illness. What they're going to do is put you now in a decompression chamber. But instead of you just having to be in there 10 minutes to get the gases to equilibrate, you now might be in there for months or years. Because once you mess up, it takes a long time to be able to come back out of that pressurized chamber. So it's very harmful to your body. You don't know if you'll get away with murder or if it'll do you harm and your brain will be destroyed forever or some other important part of your body. And then you've got all that time you're now going to have to be in a decompression chamber. Okay, so that's Henry's law, and the bottom line is the higher the pressure, the greater the solubility of gases. So that's directly proportional too. Now, actually, going down isn't totally a guilt-free moment. If you go down and you stay too long, the main gas that you're breathing is nitrogen. And when too much nitrogen dissolves in your bodily fluids, it makes you euphoric. It makes you lose your judgment. And so you may decide, oh, I don't need this VC and this regulator. And you may take all that gear off. That's your breathing apparatus. Or I don't need this thong. You might take that off. So we may find you floating downstream at midnight, dead, because that's called nitrogen narcosis, when you lose your ability of sound judgment because you have too much nitrogen dissolved in your body. That's why they tell you most people shouldn't be diving below about 60 feet if you're very inexperienced. If you dive 90 feet, you're only allowed to be down there something like 10 minutes, or you're in jeopardy of getting nitrogen narcosis. So you could see how people could make that mistake. They just stay down a little bit too long because they were seeing very interesting things. Okay? All right. Are we okay on Henry's law? You're just going to have to think of some diver named Henry. Okay. Probably the name of the barracuda. He's hungry. You ever seen a barracuda? They're scarier looking than a shark when you're down there, because you can see all their teeth the whole time. They're sitting there, that eyeball watching them. Oh my God. Swimming numbers. Your percentages of making it back to the boat are better. Of course, I always had boys, and they'd always sneak up behind you and grab your fin. You were sure you were eaten. Anyway, Dalton's law of partial pressure. I'm going to blabber a minute, and then we'll come back and make sure you've got all the parts of your notes. So in the air, there's a mixture of gases. There's oxygen, there's CO2, now we know there's nitrogen, and there's water vapor, which is a gas, so it's a mixture. And each gas exerts a pressure, and that pressure is known as its partial pressure. So here's how you write partial pressure of oxygen. Here's how you write partial pressure of carbon dioxide. So you put the little p in front of it, and that means partial pressure. And in this mixture, if you added up all of the partial pressures of the gases that are in the mixture, guess what it adds up to? The total pressure of the mixture of gases. So in the case of our atmosphere, you add up the partial pressure of oxygen and CO2 and nitrogen and the rare gases like water vapor, and it adds up to 760 millimeters of mercury. Okay? So we're going to prove that to you on the next page. Are you okay so far? So it just says, so the sum of all the partial pressures of the constituent gases equals the total pressure of the gaseous mixture. So in the case of air, it's going to add up to 760, and we're going to show you how we got all the partial pressures of these constituent gases that make up your air. Who cares? The reason we're bothering to look at this is when those gases move, like oxygen coming into your lung and CO2 exiting your lung, oxygen only moves according to the pressure of oxygen. It could care less what the partial pressure of CO2 is. So it moves from high partial pressure of oxygen to low partial pressure of oxygen. So there better be more oxygen out here in the air than there is in your alveolus, or it'll never move into your alveolus. See what I'm saying? Okay, so we're admitting that air is 760 millimeters of mercury. We're telling you that 21% of the atmospheric air mixture is oxygen. That percent is out of 100. So you take partial pressure, to compute the partial pressure of oxygen, you put 21 over 100 and multiply it times the whole pressure of the air, and you'll find out how much of that pressure is due to oxygen. If you hit that on a calculator, 21 times that divided by 100, it comes out 160 millimeters of mercury for the pressure that oxygen exerts when it's out there in the air. Got your notes?
No.
Oh, well, you can scribble, but I mean, I'll wait for you. If we're looking at nitrogen, I told you it's the most abundant gas. So the partial pressure of nitrogen is 78 over 100 times 760, and that comes out to 592 millimeters of mercury. Carbon dioxide is only 0.04%, so 0.04 over 100 times 760 is about 0.3 millimeters of mercury. And of course, we're polluting all the time, burning carbon-based fuels, and so that is going up in tiny little amounts. But it doesn't have to go up much to create those problems like the greenhouse effect that traps heat near the surface and changes weather systems and melts polar ice caps and things like that. Rare gases could be up to about 1%, so that's gas and water vapor. 1 over 100 times 760 is about 7.6 millimeters of mercury. So that's supposed to all add up to 760, so let's look at that. If we take 592, and that's, these two numbers together are very close to 8, 8 plus 592 brings you up to 600. 600 plus 160 more is 760. So that does add up to very close to standard atmospheric air pressure. Okay, a lot of discussion to get you finally to our respiratory tree and what is actually going on. So this is a very oversimplified respiratory tree. Out here is the air, okay? And out here in the air in the atmosphere. we just calculated that the pressure of oxygen is 160 millimeters of mercury, and for CO2, it's 0.3 millimeters of mercury. Then you breathe. So you're going through your nasal cavity or your oral cavity. You're going down your pharynx. You're going down your larynx. You're going down your trachea. You're going down your bronchus, terminal bronchiole, respiratory bronchiole, and finally you made it into an alveolus. So all of this is everything except the bubble, and the bubble is your alveolar air sac. Okay? Are there any valves that shut the airflow anywhere from your mouth or nose down to your alveolus? Drawing flies. I guess it's time for a bath. No. So if this is higher than this for oxygen, then diffusion is going to take over, and it's going to keep the oxygen moving down that branching air system all the way into the alveolus. So it happens that when you inhale, the oxygen level in your alveolus is 100. It's 100. Out here in the air, it was 160. So in your nose, it could be 160. So 160 is a whole lot more than 100, right? So that's going to keep diffusing down this way. This is a capillary. It says so right here. This is blood that's just come back from your body cells, so it is deoxygenated, dirty blood. In other words, blood low in oxygen. Normal low oxygen, these are what are known as your blood gas levels. Low oxygen level in your bloodstream is 40 millimeters of mercury. So that it's never going to go down to 0, it's 40. So that blood is flowing in this direction. If it's 100 for oxygen in an alveolus, and it's only 40 out here in the capillary, which way is diffusion going to go? Into the blood of the capillary. When is it going to stop? When it's what? When it's equal to what the alveolus is. So this will keep diffusing that way, and you'll build it up from 40 up to 100 in the blood. And why did this number drop down? Because from your nose and your pharynx and your larynx and your trachea, you keep bringing more back down here to replace that. So this is a constant number down here in your alveolus that's being replaced by simple diffusion that doesn't cost you one bit of energy. Okay? So that's why you have two-way arrows here saying at the equilibrium point, it's going to be 100 in your alveolus and it's going to be 100 in your blood for the oxygen. That's why when the clean blood, oxygenated blood, goes out back to your body cells, the maximum amount of oxygen will be at 100. Is there anybody who doesn't understand that? So these are showing you the way that oxygen is moving. So I'm representing oxygen with red pen. Now I'm going to represent CO2 with a blue pen. In really dirty blood, CO2 is 44 millimeters of mercury. In really clean blood, we've only blown off 4 points. It's 38 millimeters of mercury. Okay? In your alveolus, it's 38 millimeters of mercury. But look what it is out here in the air. 0.3. So where is there the most pressure due to CO2 at this moment in this diagram? In the capillary. So which way is it going to move? Out of the blood and into your respiratory tree and out to the air. So CO2 is going to, there will be a net movement for a while in this direction. But when will the net movement stop? When it's equilibrium at 38 in the alveolus and 38 in the blood capillary. And then this 38 millimeters in your alveolus is going to follow this blue arrow and go out where it is 0.3 in the atmosphere. Partial pressure of CO2 is 0.3 in the atmosphere. So it's going that way while oxygen's going that way. So those are two different gases. At the same moment, they're going in opposite directions. Neither one of them is costing you any ATP to move. They're moving by simple diffusion. And in the end, you have clean blood when it's got 38 millimeters of mercury and 100 millimeters of mercury worth of oxygen. These are blood gases you will do on your patient all the time. Because if you're in physical therapy, you can't go get a patient out of the bed whose oxygen levels are at 80. You stand them up and try to exercise them, they could pass out on you and fracture their skull, and you'd be in hot water with your job and the patient. So they put pulse oximeters on their fingers to see what their oxygen levels are. So these are things you will be dealing with out there in the clinical environment. Do you understand how that works? Do notice, however, this went from 40 up to 100, 60-point rise in oxygen levels. This only went from 44 to 38, just a 4-point drop. Yet, remember the chemoreceptors, like in your medulla, and in your pleura of your lungs, and in your carotid sinus, and your aorta? Chemoreceptors pay bigger attention to which one of these? CO2. So just a little bit of change in CO2 wakes up those chemoreceptors. That's why chemoreceptors usually are never responding to your oxygen levels, because you have to drop significant amounts before you're going to light up a chemoreceptor due to oxygen being low. Okay, if you understand that then, so ventilation, we did inspiration and expiration. Now we've done Dalton's law of partial pressure to move the blood gases from your respiratory tree into the blood, or from the blood into your respiratory tree. Now we want to say, okay, so if the blood gases are in the blood, how are they traveling in the blood? So we're trying to go all the way out to your cell and back. So we're trying to get the whole story. So let's start with oxygen in your bloodstream. 2 to 3% of oxygen that's in your blood plasma won't even go inside your red blood cells. It'll just stay dissolved, unbonded in your plasma. But that's a very little amount, 2 to 3% of the total amount of oxygen you have. 97 to 98% of it is going to bond to hemoglobin, which means it had to have entered a red blood cell, because that's where the hemoglobin is. And when it bonds to hemoglobin, it becomes that bright scarlet red pigment called oxyhemoglobin. Each time you bond something different to hemoglobin, the color of hemoglobin changes. And we know that your red blood cell hangs on to oxygen better if it's cooler temperatures and it's more basic, more alkaline. So it'll let go of the oxygen when you're hot from exercising or exerting, or if you are acidic, and acidic wastes are typical things that you make when you've been busy and exerting. So we've had this story before. Okay, so most of it's hooked to hemoglobin. Let's see how carbon dioxide is traveling in your blood. 7% of carbon dioxide is going to stay out there in your plasma, but it naturally bonds to water. So here's water, here's CO2. When it bonds, it forms that buffer in your plasma, carbonic acid. So that's how you got it, carbonic acid. And notice that's reversible, so this can come back apart later, and we'll see where it does eventually. 23% of your CO2 is going to go inside your red blood cells. But there is another waste from breaking down proteins around your body you're constantly having NH2, NH3 groups, ammonia type groups in your blood plasma. So there's one of those, NH2. So the carbon dioxide and the NH2 are going to bond to hemoglobin. And so the compound is carb for carbon dioxide, amino, because a nitrogen group is an amino group, carb, amino, hemoglobin. It's like you're naming it from the back end forward. That's the name of what the most common way that carbon dioxide bonds to hemoglobin is. It also picks up an amino group, so it forms carbaminohemoglobin. That only has taken care of less than a third of the carbon dioxide in your blood. 70% of the carbon dioxide undergoes what is known as the chloride shift. So I'm going to explain the chloride shift to you down here. So again, CO2 goes inside a red blood cell. And inside a red blood cell, there is water, and the CO2 will bond to water inside the red blood cell, and guess what it forms? Once again, it forms carbonic acid. In the red blood cell, there is an enzyme that encourages it to form the carbonic acid. The name of the enzyme is carbonic anhydrase, so that's what's written on the arrow right there. And so now I'm going to abbreviate that with Ca. So you no sooner have formed the carbonic acid than carbonic anhydrase, Ca, encourages that compound to go further and break apart, but not break apart in this form, to break apart with an acid, H+, and then the whole rest of the molecule is HCO3-, which is the other buffer. That's bicarbonate ion, which at this moment in time is inside the red blood cell. Don't lose track of where you are at the moment. Okay? That's a negative buffer. So when you are at active cells and CO2 diffuses out of the active cell into your blood, it tends to drive this reaction this way. And so it's floating along inside your red blood cell like this. Now, hydrogen happens to love hemoglobin. So it is not inclined to leave the red blood cell and go out to your plasma because it really likes hemoglobin. So you've got all of these positive H pluses in there inside your red blood cell. What's the story about positive charges? They attract the opposite, which would be a negative charge. The most abundant anion, the most abundant negative charge in your extracellular fluids, and plasma is an extracellular fluid, is chloride ion. So that's why that's going to shift in from the plasma where it was to enter the red blood cell to be near the positive hydrogen that has accumulated in there. That's why this mechanism is called the chloride shift. But because of all that negative coming in, who does not like negative? Another negative. So where is that going to go? Out of the red blood cell to the plasma, which is a lucky thing for us because that put that protective buffer that protects us against acid waste out there in our plasma to help us. So now you see how both of the buffers ended up out there in your plasma. Are we okay? What were we toting in this equation? Carbon dioxide. So where is the carbon dioxide at this moment in time? Tied up as part of what? As part of the bicarbonate ion. Yes, there's your CO2. So if you need to make a note, say, remember the CO2 is right now part of the bicarbonate ion out there in your plasma. When you're in your car and you're putting your chapped lip medication on your lips, what are you exhaling at the level of your lungs back out your respiratory tree? CO2 and what? Water. So this is the direction it drives when you're at your cells and the capillaries near your cells. When you're trying to exhale it at the level of your lungs, it's got to come back this way because we got to get back to the gaseous forms that we can exhale. So this is a really, really important equation to know in the respiratory tract. This is when you're at the level of your active cells. This is what happens when you're back at the level of the lungs as far as taking care of CO2. Okay? All right. So we got our oxygen toted along in the blood, most of it bonded as oxyhemoglobin. Now we've got our CO2 traveling along in the blood, most of it in the bicarbonate ion thanks to the chloride shift, a little bit of it in carbaminohemoglobin, 23%, and a little bit of it out there in your plasma as carbonic acid. Are you with me? Now we're at the level of cells. So we're really talking about oxygen at the level of cells, okay? So there's a very famous guy. He must have been a wizard. His name is Bohr. Bohr did one of the models of the atom, telling you about electrons and protons and clouds and all that, remember? Well, he also is telling you what happens with oxygen and why your blood gives up oxygen when you get to the level of tissues. So that's what the Bohr effects are. It's factors that explain why your blood releases the oxygen that was oxyhemoglobin to your cells. Okay, I'm a cell and I've been busy. What's my temperature? Hotter or colder? Hotter. So when you're at active cells, only active cells, you'll have a higher temperature. Do active cells need oxygen? Yes, because they used up their last load. If you're an inactive cell, we're probably not even going to open up your sphincter and let the blood even flow near you. You didn't use up your last load of oxygen. Remember what I told you about bonds. This is not a bond. This is a bond. And when it's high temperature, that's more energy. It's more excited. So it'll be like this more often than it's like this. It comes apart more when it's a high energy situation. So we're at higher temperature if we're at a busy cell. Therefore, things are getting broken off easier. So, and in active cells, we have a lower pH. So, acidity. And what do we know about the hemoglobin being able to hold on to oxygen? It can't hold on to it as well when it's hot and it's acid. And we've got heat and we've got acidity if we're at an active cell. So, it's tending to make the hemoglobin let go of its oxygen. If that isn't enough, there are other things there that want to grab the hemoglobin. There is acidity in these active cells. So the acid particles from the active cells want to bond to hemoglobin, because I already told you H plus loves hemoglobin. Your red blood cells make a waste. The name of this waste is BPG. It's called bis-phosphoglycerate. You can just know it's a waste, but if you're curious, glycerate is a 3-carbon chain. Bis is just telling you which carbon it's bonding to, the phosphate group. So the second carbon, bis-phosphoglycerate. But anyway, who cares? Because this waste from red blood cell also likes to bond to hemoglobin. So you got oxygen that kind of wants to be on hemoglobin. You got hydrogen that's accumulating in the dirty cell. It wants to bond to your hemoglobin in your red blood cell. And now you've got BPG, a waste from red blood cells that wants to bond to the hemoglobin. So you got 3 things competing for the hemoglobin, and the bonds are letting go all the time. So when the oxygen lets go, there is more oxygen in your blood right now than there is in that active cell, because the active cell used up its oxygen. So the diffusion gradient is going to tend to drive the oxygen out of the blood where it's higher into the cell where there wasn't much oxygen. So that's why your cell gets oxygenated. You got more oxygen in the blood, less in the cell. Once you break the bonds off, then oxygen will move from the pressure gradient from the blood into the cell. Are you okay on that? Okay. We're back at the level of the lungs. So this is at the active tissue cells. This is back at the lungs. This is called the Haldane effects. And Haldane effects are trying to explain to you why CO2 lets go of hemoglobin or decides to stay bonded to hemoglobin. In other words, or whether it stays in your bloodstream. So are you going to be able to exhale the CO2 out your respiratory airways? That's what Haldane effects are trying to explain. If you don't have very much oxygen entering, there isn't something to knock the CO2 off the hemoglobin, and therefore CO2 will remain bonded. This is the summarizing big picture. If you have a lot of oxygen coming in, the oxygen wants to bond to the hemoglobin, and that'll help you release your CO2 and be able to exhale it. So that's just the summarizing statement. Now let's see what's going on. Hopefully you're breathing correctly. So if you are, there's more oxygen at your lungs. And therefore, any CO2 that's released from your blood would tend to diffuse out of the blood where it's higher CO2 into the lungs where we've just learned it's 38, less CO2. Okay? What we're fixing to see is this equation going back this way. So in a nutshell, this is going to kind of be a reverse chloride shift. All right? So because of inhalation on the previous page, oxygen entered the bloodstream. Oxygen, some of it, not instantly all of it, some of it will form oxyhemoglobin. In other words, it bonded to HB, hemoglobin. When that happened, remember who loved hemoglobin? Hydrogen did. So a tiny bit of the hydrogen that used to be attracted to hemoglobin is displaced. And since the oxygen has its bond site, some hydrogen goes out of the red blood cell and is out there in your plasma. And this keeps happening at a very slow rate. Well, if you keep doing this, having this stream of hydrogen leaving to go out to the plasma, who's going to follow behind all these positive charges? Chloride ion. That's your reverse chloride shift. So now that's leaving the red blood cell and going back out to the plasma. Because all that negative went out to the plasma, who that's been sitting in your plasma goes, I don't think so, I'm going back inside the red blood cell. Who is this going to repel? What kind of charge? A negative. Lights repel. And so the only negative thing out there we've talked about is bicarbonate ions. So the bicarbonate comes back inside the red blood cell because the chloride went out. When the bicarbonate ion comes back inside, there still is that trickle of hydrogens coming off of hemoglobin. So this finds some of those hydrogens that are coming off the hemoglobin, and guess what that's going to form? H2CO3. And the enzymes that you have in your lung make this come apart as water vapor and CO2. And that's why those are what you exhale. So we did just drive that equation on the previous page back to the left, because these were the two things on the left on the previous page that we exhale. If you have lots of oxygen, Haldane effects will displace the CO2 and you exhale it. If you don't have much oxygen, then the CO2 gets to remain bonded and you won't go through this reverse chloride shift. Are you okay on that so far? Okay. Were you breathing all day long? Were you thinking about it? You are now. This is a weird nervous control. Most of the time, your respiration is controlled by nervous tissue, unless the gases get out of balance, and then something else will take over, and we'll get to that in a minute. So that's why we say nervous tissue, neural controls, are the main control in your breathing. It's usually involuntary until I've brought you consciously aware of it. So if it's involuntary, it's under the control of the ANS, autonomic nervous system. Okay? And you studied skeletal muscle in Anatomy 1. Intercostals, whether internal intercostal or external intercostal, diaphragm, serratus anterior, trapezius and rhomboids underneath that, and levator scapula underneath that, and abdominal muscles. Are those voluntary? Can you make your abdomen compress if you want? Yeah, or sort of. You know, so what is weird about that is you have an involuntary nerve that is going to go control voluntary muscles. That's not usually how our body behaves. It will if it's a reflex to protect you against somebody hitting you in the head with a baseball or something, but except for things like that, normally voluntary organs are controlled by voluntary nerves, but this is one isn't. This is a case where involuntary nerves come down in synapse with some voluntary nerves. Your voluntary division of your nervous system is called the somatic branch. So the involuntary nerves are going to link up in synapse to voluntary ones, and that's why it goes to these voluntary skeletal muscles and will cause them to contract for inhalation or exhalation. So if you were asked, where's your main center of respiratory control? It's in the oldest part of your brain, the part that keeps you alive, the part in Anatomy 1 that you were told controls vital reflexes. Vital reflexes are reflexes you're dead without. So this is a center that controls heart rate, it controls blood pressure, now you're finding out it controls your respiratory rate, it keeps you from going into a coma so you're alive. What part of the brain is this? Your medulla. And it's in the part of your brain known as the brain stem. The brain stem is what makes you a living person. So you could be a vegetable, not being able to interact, but your brain stem is alive. And you could have not even developed eyes and ears and things like that. You could just have holes in your bony orbit. And you would be alive if you had a brain stem. Okay? Above that, your cerebrum, that's the newest part of the brain that developed, and that's your intellectual decision-making center. And so it'll kick in every now and then, like right now when I said, are you aware that you're breathing? Well, that's your cerebrum taking over for a minute, thinking, shall I breathe quicker, slower, deeper, not, shallow? You know, that's it. Okay, but normally your medulla is in charge of it. Now, if you've read the respiratory chapter in your book, there are still many things about your respiratory system that is not fully understood. So we just admit that right off the bat. But what they think is, in the medulla, there is an inspiratory respiratory center in the medulla that will trigger you to inhale. So that would be the go-go-go side of your autonomic nervous system. So the go-go-go side is the sympathetic nervous system. So autonomic nervous system, specifically sympathetic nerves, are firing. And they fire to a voluntary nerve plexus that came out your neck and went to your heart, but it also goes to your lungs. Those are cervical nerves. You studied those white voluntary plexi, networks of nerves, in Anatomy 1 on that vertebral column model. All those white snarls of nerves were voluntary plexi. So that is a somatic nerve. That will go over to a nerve that ran down your inferior vena cava and spread down across your diaphragm to innervate or cause your diaphragm to contract. So that was called the phrenic nerve in your pig dissection. Okay? So that's causing contraction. At the same time, some of the cervical nerves are branching across your external intercostal muscle, making them contract. So the nerves that go to intercostals are intercostal nerves. So I circled it at the point that your involuntary system synapsed with your voluntary system. So what they know about making you inhale from the medulla is pretty well understood. That's not where the question comes in. Exhaling is where some of the arguments come up. Some people think exhaling is just passive, that somehow you're blocking the ability to inhale and therefore you passively exhale. But then we still have the internal intercostal that contracts, so there's got to be some nerve innervation. So what we think happens is now it's your parasympathetic nervous system that's firing, and that's going to trigger internal intercostal muscles to contract, which pulls your rib cage down and in, and therefore you exhale. So we do think there is an involuntary nerve that's once again going to go to intercostal nerves and this time trigger the internal intercostal. This is by way of intercostal nerves again. Now, the name of the parasympathetic nerve that triggers expiration is the vagus nerve. The vagus nerve. And at the same time, you're making the internal intercostal pull your ribs down and in. Your diaphragm's not contracting anymore, so it's just relaxing back up. And obviously your external intercostals are relaxing as well. So these are not being stimulated right now. The one thing being stimulated is your internal intercostal muscle. Now, when you were, this is what is thought. How do we know when to trigger the vagus to fire and make you exhale? And it is thought it's due to some stretch receptors. There are some stretch receptors that are in the alveolar air sacs or intimately associated with the alveolar air sacs. So when you're inhaling, you are distending, stretching, inflating, however you want to say it, your alveolar air sacs. The more you inflate those alveolar air sacs, what are you going to do to the stretch receptors that are all over their surface? Yeah, irritate them, trigger them to fire. And so it's thought that the stretch receptors do not want you to overinflate your alveolar air sacs, and so they fire, and that's what causes the vagus nerve to cause the exhalation or expiration effort. So this is known as the Herring-Brewer reflex, and it's a reflex to make sure that you don't overinflate your alveoli. You don't breathe too deeply. But it's using the parasympathetic nerve pathway to trigger an expiration. Well, none of that's too scary. But there is an area in your brain called the pons, or the pons virolii. If you have a stroke and it damages the pons, or if you're in severe trauma and it damages the pons, or if you're on certain narcotics that inhibit the pons, immediately that patient starts having erratic breathing rhythmacy. So although the medulla is the king cheese of your respiratory system, respiratory rhythms are always sent from the pons to the medulla. And so this has a lot to do with the rhythmacy of your breathing. And it's very important to your respiratory system. So the minute you damage it, we start seeing all of that starts going haywire. So you could kind of almost name it the pacemaker of your respiratory system. How does it do the pace thing? Because in the pons, there are two different clusters, nuclei, of nervous tissue. One is now renamed the PRC, the Pontine Respiratory Center, because it's in the pons. It used to be known as the pneumotactic center, and that phrase is still in your book. So it's either or, you can call it either or. But that triggers you to exhale, okay? That's making sure you're not continuing an inhalation effort too long. The other cluster of nervous tissue in the pons is a nucleus that's making sure you don't go without a breath. Respirations is P-N-E-U. Pneumo means respirations, breathing. A is the absence of. So the apneustic center is a center that's making sure you do not go without a breath, that you do not have an absence of breaths. So it's triggering inhalation. Let me give you a couple of examples how that works. Let's say you did make it to the holidays and you're going to have a good night out with your significant other. So you're in there, men shaving, putting on the smell good stuffs. The girls are in there twirling their eyelashes, getting all cuted up. And you've got that little 2-year-old girl. Where are you going? Am I having Sally as a babysitter? I don't want to have Sally as a babysitter. I don't want to stay home. No, no, no. She starts throwing a wing-ding flinky. You put her in your bedroom and slam the door. Go in there and behave until you can act nice. You stay in there. She's in there kicking and hollering on the floor. I hate you, I hate you. I'm going to hold my breath till I die. Fine, you do that. This is, who would ever act like that? But anyway, that little brain cell you gave birth to in there on the other side of the bedroom door is now using her conscious decision-making center, her cerebrum. I'll fix them. They're going to go have fun without me over my dead body. I'll hold my breath. So her cerebrum tells the pons then, pontine respiratory center, no inhale. And so the pons fires to the medulla, and therefore it's going to the medulla's expiratory respiratory center. And so there's no inhale. But if that kid is that hard-headed, and usually the smart ones are, she may hold her breath for a minute, but what's going to happen to her? Then she passes out. The minute she goes unconscious, this isn't the center of her brain that's going to control anything again. Now it goes right back under the control of pons to medulla, and the pons in the medulla are going to trigger the respiratory efforts again. So no one can hold their breath to kill themselves. No one can do that. Okay? If you were in the doctor's office and he was trying to listen to your breath sounds and he said, I need you to take a very big inspiration, then you're using your cerebrum instead to trigger the pons, but this time the apneustic center, so that you send that to the medulla, specifically to the medulla's inspiratory respiratory center. And that triggers you to inhale. So there are moments here and here where we do consciously control our breathing. But most of the time it's just pons to medulla, keeping it going based on the blood gas levels. The CO2 and the hydrogen are the first things monitored. There are all sorts of things that I'm not talking about that also can affect the pons and therefore the medulla and your breathing rates. Cold can affect it, inhibit it. Light can affect it, really bright lights. Certain medications can affect it. So pain can affect the pons and therefore your breathing rate. So we're just sticking mainly to the general way the respiratory tract behaves, but there are a lot of other things that can feed in through the pons to the medulla and affect temporarily your respiratory rhythmacy. Okay? Now, it would normally be controlled by your autonomic nervous system. Cervical nerves go, vagus stop. back and forth, back and forth, back and forth. But if for any reason your CO2 levels or your hydrogen ion partial pressures get elevated, then and only then your breathing becomes controlled by your chemoreceptors temporarily instead of by your pons and medulla. So this only does it when your gases are out of the normal ranges. And these chemoreceptors, we've talked about briefly before, are in your carotid sinus, where the internal and external carotids split apart from one another, in your aorta, in your alveolar air sacs, and in the cerebrospinal fluid, senses them in the medulla tissue, the nerve tissue of your medulla. The reason CO2 is partnered with hydrogen ions is usually when CO2 is going up, so are your acid levels going up. And what is oxygen doing at this same time? Going down, yeah. But we'll come back to the oxygen comment in a minute. If you have too much CO2, so hypercapnia means elevated CO2, then you've got more CO2 bonding to hemoglobin. And CO2 hooked to hemoglobin is crimson, more blue blood. So what does your pigmentation start looking like? Blue. So the description of your skin tones is you are cyanotic. That's the color, the hue. You have blue hue as opposed to tissues that would look pink. Osis, a condition of being cyano, blue. So maybe the lips, maybe the fingertips, digits, and things like that. They look at stuff like that when they're, if you're in forensics, doing autopsies, and you've got a little infant that comes in and you don't know whether the infant, you thought it was SIDS, sudden infant death syndrome, but if they were suffocated, it turns their tips of their digits are cyanotic or blue. And so that's one of the signals that, and they'll look for other things too, petechiae and all kinds of things, ruptured capillaries and stuff in areas of the internal body organs. But in SIDS, it doesn't do that on the fingertips. So they know that that baby was helped to death if they start seeing things like that. Okay. So if we have way too much CO2, we need to speed up or slow down our ventilation. Speed up because we want to blow it off and we want to get some more oxygen in. So we're going to speed up our ventilation, but we need to slow down how fast the blood rushes through our lungs. So what do we do to the arteries on the way to the lungs? Constrict them, because that'll let the blood flow through at a slower rate. So we're going to vasoconstrict the arteries to the lungs, and this will slow the velocity of the blood so we have time for the exchanges. We're going to speed up our respiratory rate and how deeply we breathe each breath. And by the way, at the same time we're speeding up our respiratory rate, what are we doing to our heart rate? Yeah. And what are we doing to our blood pressure? Elevating it, yeah. So these three things parallel each other. If respiratory rate is elevated, then heart rate and blood pressure are elevated at the same time. So normal partial pressure is 38 millimeters of mercury, and normal partial pressure of oxygen is 100 millimeters of mercury. When you get any higher than 40, that's when these things are going to start to happen. That's when you're going to slow down the blood flow by vasoconstricting the artery. That's when you're going to breathe faster and deeper. and your heart rate's gonna go up and your blood pressure's gonna go up. When you exceed 40. You only have to get this clean. You only have to drop from 38, your normal low of CO2 in your blood, down to 35. When your alveolus detects 35, that's too clean. Then your brain says, you don't need a breath. So that triggers you to go into that apnea, that inability to get a respiration, a breath. And that's when they make you breathe in a bag so they can talk some sense into, so you quit hyperventilating. Look how far you have to drop from 100. You have to drop 40 points, 30 or 40 points down to 60 or 70 millimeters of oxygen before chemoreceptors will trigger all this if it's based on oxygen. So that's why usually chemoreceptors aren't paying attention to oxygen. They're paying attention to hydrogen and CO2 levels, because CO2 only has to move 2 points. Okay? All right. So oxygen is monitored, but it's rarely the one. That basically is our coverage of the respiratory system. So I already gave you your respiratory lecture study guide back when you took your last test. Just go through it, see if you understand it, start studying this, because you have all next week to get back and ask me questions so that you do really well a week from Monday on this test. So if you came in late, the respiration test is a week from Monday.